And we are back. Hello, hello, hello. Welcome, ladies and gentlemen. Welcome back to day two of the International Webinar on Education X COVID 19 Pandemic. My name is Alpha Johan, and I am your main host for today's session. If any problems occurs or if you would like to ask any questions, kindly write them up in our chat box below. Shortly, we will be talking about the COVID 19 pandemic, infection, prevention, and outbreak control from 2:30 p.m. to 5 p.m. Malaysian time or UTC plus 8. To begin, I would like to invite our moderator for today, Ms. Fatin Maisara, to guide this session with not one, not two, but three speakers from three different countries. Alright, let's begin. Ms. Fatin Maisara.
All right, thank you so much to our MC today, Miss Alpha. So, hi, I am Fatima Sarah binti Sadruddin, your moderator for today's event. So, our topic for this glorious day is COVID-19 pandemic infection, prevention, and outbreak control. Without further ado, let's get to know with our three amazing guest speakers today that will discuss the issue. All right. So, firstly, we have Associated Professor Alex Richard Cook, Vice Dean for Research and the main leader in Biostatistics and Modeling, Saw Swee Hock School of Public Health, National University of Singapore. He has completed his Bachelor Science honor with first class and PhD in Statistics for Research at Biomathematics and Statistics Scotland in Heriot-Watt University, UK. Various top-notch books that he has published, such as Evaluating Smoking Control Policies in the E-Cigarette Era, a Modeling Study, Institutional Not Home-Based Isolation Could Contain the COVID-19 Outbreak, Estimating the Size of a COVID-19 Epidemic from Surveillance Systems, and the list still go on. What a great profile. So, Professor Alex, how are you today? Thank you for joining us from Singapore.
I'm very well, thank you. Thank you for the invitation.
All right. So thank you so much, Professor Alex. Okay, now we move on to our second guest speaker, which is Associate Professor Dr. Rafdzah binti Ahmad Zaki, the head of Research Center, Faculty of Medicine, University Malaya. She completed her Bachelor of Medicine and Bachelor of Surgery in Liverpool University, UK, and completed her Master and Doctorate in Public Health at University Malaya. She is also an expert in research methodology, validation study, and epidemiology. Some of her outstanding medical journals are Respiratory Circulae and Quality of Life in Children 1 year after being admitted with a lower respiratory tract infection, a prospective cohort study from a developing country, bacterial pneumonia and its associated factors in children from a developing countries, a prospective cohort study, and clinical symptoms of arboviruses in Mexico. Okay, we also have a good profile from Professor Rafdzah. A lot of research she has done. So how are you, Prof, today? Looking good, I think.
I'm fine, thank you. Thank you, Fatin,
Alright.
and thank you all the organizing team for inviting me today.
All right, thank you so much, Professor Rafdzah. For your information, Professor Rafdzah is from Malaysia, our guest speaker, and Professor Alex is from Singapore. And now we have our third amazing speaker, Dr. Yodi Mahendradhata, which currently the Vice Dean for Research and Development, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. He is a medical doctor by training and he obtained a master's degree in international health from the Institute of Tropical Medicine, Charité Medical Faculty, Humboldt University, Berlin, Germany. Dr. Mahendradhata also has completed his doctorate in medical science at the Institute of Tropical Medicine, Antwerp, Belgium, and Ghent University, Belgium. He is currently leading the Southeast Asia Regional Training Center for Health Research supported by WHO TDR. He has led developments of National Strategy for Implementation Research, National Strategy for Tuberculosis Control, and country proposals to the Global Fund to fight AIDS, TB, and malaria. So, Dr. Yodi, how are you doing from Indonesia?
Alhamdulillah, I'm fine. Thank you very much, Fatin, and thank you for the invitation.
All right, thank you so much, Dr. Yodi, and all of the guest speakers today. All right, I would say thank you very much again for our guest speakers for allocating their time with us, especially it's weekend, right? Today, so to share out their thoughts and opinions regarding today's matter. So before I give the floor to our guest speakers to present their presentations and discussion about the topic, let me just brief a bit actually about what our guest speaker will discuss and present today. So, ladies and gentlemen, COVID-19 doesn't belong to any races, color, and social status. It will eventually infect those who are infected by contact or simply air droplet, forcing us to live in the new norm of following 3W, which is wash hands, wear masks, and warn us from crowded places. So in today's session, we will get a better insights from all of our guest speakers regarding the COVID-19 situation and management in each respective country, COVID-19 prevention and vaccination program, and lastly on how to prevent this pandemic from occurring again in future. So without wasting any time, let's just invite our first guest speaker, Professor Rafdzah, to share with us on how Malaysia handled the situation and COVID-19 outbreaks. So, Professor, you may present your presentation now. The floor is yours.
All right. Thank you, Fatin. So I will share my slide now. Yeah. So before I start, actually, the topic given to me is actually the outbreak control and prevention, and also in the end, I was asked to talk about the lesson learned from this pandemic. So that's how the flow of my presentation. Of course, later on during the Q&A session, we can have more question on that. Okay. Okay, I hope you can see my slide now.
Yes, we can see it, Professor Rafdzah.
Okay, so as Fatin mentioned, I'm Dr. Rafdzah. I'm currently a public health medicine specialist from the University of Malaya Medical Center. So I also head the Center for Epidemiology and Evidence-Based Practice in University of Malaya. So before we talk about the infection prevention, outbreak control, I think it's very important for me to start with the we need to understand the concept of the infectious disease itself. So what is actually infectious disease? So I try my best to use the lay term as possible because I know that this session we have a different background of views. So what we mean by infectious disease is actually a disease that caused by a pathogenic microorganism, means that it can be different type of microbes, either bacteria, virus, protozoa, and many others. So when we talk about infectious disease, this disease actually can be spread directly or indirectly from one person to another. So when the disease transmission occur, so there are a few terms we need to understand. The first one is what we call index. Index case is actually the first case that identified. And then we have a primary case, which is the case that bring the infection to into population. Usually the index and a primary case is the same, but sometimes it might be not. Okay, so and then the if you look at the chart here, so the rate color is actually representing a clinical case, mean that patient who are actually already infected. So we label P here as a primary case, mean they are the first case that bring the case into our population, and this person actually will interact with others surrounding him or her and will actually transmit the disease to a second person. Yeah, so the next one label S is actually as a secondary case where infected by a primary case. So if you notice that this one case here is actually labeled as blue, light blue, which is I put as immune, means that some of us already have a much stronger immunity in our body, especially when we have vaccination, for example. So even though the person exposed to the infected people, they will not get the infection. So this transmission will goes on and on until we don't have any more susceptible population, which is a person who are actually free of disease at the initial stage. And when the person got infection, they can become subclinical first before they have a clinical symptom. So I think now by now you are familiar with the term what we call R naught. You know, when the MOH given their statement, they say the R naught is 1 point something and so on. So what R naught mean, or is actually a reproductive number. So from a one case, how many cases that this disease can lead to? So for example, is this one person can lead to a 3 case, so the R naught is actually 3. So that's a simple way of explaining R naught. But actually, when we have further intervention, the reproductive number is actually changing over time. So that's one in terms of disease transmission. The next I would like to explain is in terms of the dynamic of infectiousness and also the dynamic of disease. Because when you have infection in your body, okay, first you are free of the disease, what we call a susceptible state. So when you have exposed to the virus, for example, you got the infection, but before you become infectious, meaning you can transmit the disease to others, the virus in your body maybe start to replicate, but at that time you will not be able to transmit first. We call is actually a latent period. Then after a one time, then you become infectious, and then once the you are recovering from the disease, then you will become non-infectious again. Okay, if you look at the dynamic of the disease, okay, once you got infection, you will have a period what we call an incubation period, where the time the first that you expose to the infection to the time that you become symptomatic. Okay, and then after you become symptomatic, of course you will recover, then you become non-disease again. So if you look at the timeline, there's a time when the infectious period and the uh, incubation period is overlap, means that there's a possibility that even though that you don't have any symptom, yeah, but you can become infectious, means that you can become transmit the disease to others. This is the concept that we apply the quarantine period. So when you exposed to a positive case, you will not develop the disease immediately. It will take times to develop. So that's why it's important for you to be in quarantine until the incubation period is over. So for COVID-19, we talk about 14 days. So after the 14 days, you don't have the symptom, you are free of disease, we are confident that you are not get infected, then you can complete your quarantine period. So this is where we apply the prevention. Depends on what stages it is and what time period it is. Okay, the next concept that I want to introduce is what we call a chain of infection. Okay, when we hear the media say putuskan rantaian, break the chain of infection. This is what is actually what we mean by chain of infection. Chain of infection is actually a process of infection that start with the agent or the pathogen. Here when we talk about COVID is of course the virus, okay, that begins to leave that reservoir where the virus occur, where it stay for. Here the example now is in the infected human. So all the virus in their body, and then that the virus can escape, mean of escape, and through some sort of mode of transmission to enter through a mode of entry to another person, and the person become ill again, then that ill person can become a reservoir of the pathogen again. So the cycle is continue until you break the chain. So what is COVID? I'm sure by now all of us already know. Okay, just to recap a bit. So it's caused by a virus that named Severe Acute Respiratory Syndrome, coronavirus 2, okay, SARS-CoV-2. And this disease has named coronavirus disease 2019, where we known as COVID-19 now. And the term coronavirus refer to the crown-like projection from the virus, which looks like crown. And this coronavirus is actually come from a large family of virus that commonly occur in many different species of animal like camel, cattle, cats and bats. So many coronavirus are present in animal but they do not affect human. However, virus do mutate, and this when they mutate, this will allow them to infect human and spread between human to another human. So, and in fact, most virus causing a mild disease to humans, such as the common cold, okay, but the SARS-CoV, okay, severe acute respiratory syndrome, coronavirus, MERS-CoV, Middle East respiratory syndrome, and recently SARS-CoV-2, or we know as COVID-19, causing a major outbreak or severe respiratory distress syndrome. So when the first we have this outbreak started, okay, my team tried to compare a different coronavirus that we have, MERS-CoV, the first SARS that we have, and the second SARS, or we know as COVID-19. So at that time in February 2020, just a few months after we start having the outbreak, we already have like more than 65 plus thousand of cases at that time compared to the other infection of coronavirus, where MERS-CoV, during the MERS-CoV outbreak, we only have about 2,000 plus case. SARS have about 8,000 plus, but you know, within a few months of the emerging of the virus, we have 65,000 plus. But if you compare the mortality rate, MERS-CoV has much higher mortality rate of 35%. SARS have a mortality rate of 9%, while COVID-19 have a mortality rate about 2.4%. But even though the mortality rate is not that high, but because you have number of cases is high, so you will still see a high number of deaths. Yeah, and since the February and March, the number of cases is really actually raised exponentially. Within a few months, we reach a 5 million of cases throughout the world. Okay, and the situation now, what you can see that we have more than 220 million of cases worldwide, and almost 5 million deaths that we have reported, and with a death rate or mortality rate of 2%. Okay, if you see the graph, the case keep having we keep seeing a case every day until now. And in Malaysia, we have more than 2 million cases with about 23,000 deaths, with this death rate of 1%. So looking at the scenario in Malaysia now, so since the first case that we have in Malaysia, I would say that the first cases that we have are actually mostly imported cases. And in March, where we've been hit by the second wave, we call this a second wave, a small peak here. If you zoom in this part, there's one peak in March where this actually started with a cluster in Sri Petaling, where they have like some religious gathering that causing the outbreak. And on the 16th March, we declared movement control order, and which took effect on the 18th March. Okay, this managed this at that time we have like a total full lockdown, and managed to slow down the transmission, and cases actually were going down at that time. And in fact, there's time where we have like 1 or 0 cases of new case reported in July. Okay, but with this total lockdown, it actually gave impact to everything in our life lah, economy, mental health, many other factors, many others sectors actually influenced by this full lockdown MCO. So because of that, the government introduced some measures. I think yesterday our speakers already talked about the MCO, EMCO, targeted EMCO, and then recovery MCO. So all these restrictions were put in place at stages, hoping that they want to control the movement of population, because we know that the main mode of transmission is actually through the droplet, or in fact, it's a close contact between the case. So by having this lockdown, we can reduce the movement of population, and then we can promote the physical distancing, and then we hope that we will able to reduce the number of transmission that occur. Okay, so in fact we managed to bring down the cases in June, July, but when the cases go down, many SOP were relaxed, and also many SOP not followed. Okay, even the quarantine were not taken seriously. People start to question, oh, why we need to have quarantine when we have low number of cases. Okay, we start to have gathering. So in fact, what happened, I think that most of us know that actually trigger the next wave is actually what we have, the election in Sabah, when we know that at that time Sabah have higher number of cases, but we don't implement a quarantine after people travel back to other state after they going for election event in Sabah. So I mean, in fact, there are many other event where people don't take the SOP seriously, and then they don't follow the quarantine of 14 days, something, because cases is gone down. We can cut down the number of quarantine, because they don't really understand what is the reason why we do the quarantine and so on. In fact, you have to wait for to declare an outbreak is over. You need to wait for 14 days of zero case, then we can really safe saying that the outbreak is over. So but with still we have few cases, means that the cases is still going on. So then when the cases already in a community, then it's very difficult to control, and then you can't really do a total lockdown forever, because we know that if it impact everything in our life, it impact the health, economic, the mental health, the education, and many other things. So that's when we have the next phase, we can't afford to do the same full total lockdown that we had in March. But the impact, if you can see that, it's much more difficult to control compared to what we have during March time. Okay, however, what we continue to practice the SOP, and then when we introduce the vaccine, we see that there's a reduction in terms of the severity of the cases. Okay, and then there's another challenge after that. Okay, with the mutation of the variants, we see a different variant that actually causes more transmission, that actually cause another peak sometimes in July, August, in here, if you can see. So to control and prevent the disease, so the most important thing, you need to look back at the chain of the infection. Okay, even if you can break one of the link, and infection will not occur. Either you break this part, the reservoir or the mode of transmission, the cycle will not continue. You will break the transmission. So first, let's say we look at the pathogen, pathogen itself. So what we can do, we can kill the pathogen, okay, that you can stop the spreading to another human. But the problem is, at the moment, we don't really have a specific antiviral for COVID, but they do use some antiviral at the early stage of the treatment, okay, but it's not really specific for COVID-19. That's a problem with any virus diseases, not only for COVID-19. Okay, we try our best to kill the virus, but it's difficult. Then we can go the next step is actually to tackle the reservoir. So we know that now the person who are infected are actually the carrier of the virus. So we want to prevent the contact of others to this infected person. So if you are infected, you need to be isolated. So you need to be isolated from others so that you don't spread the virus to others. But sometimes, it's difficult to isolate. If you need a really good support, if you want to stay in a room, you need to have a proper facilities in the room, or somebody to help you to prepare your meal for the isolation process. Another thing is to prevent contact of possible carrier is you do a quarantine among those who are actually already exposed, because they might become a carrier, they might become infectious, but you still don't know. So you quarantine these people until they are finished their incubation period. Okay, if you fail to do this, the next step is to prevent it from escaping. So we know that it can come out if you cough, sneeze, yeah, you can cover. And the best way now, what we are practicing, we are asking, or everybody is wearing mask, surgical mask. Surgical mask, the purpose is actually to prevent the virus going out from you if you are actually infected. So it's not it's actually more protecting others if you wearing a surgical mask. But if everybody is actually wearing mask, it's actually we are protecting each other. Then next is mode of transmission. We want to prevent the transmission. We know it's droplet. If you cough, yeah, the droplet can be on the surface. Okay, so one way is if you touch anything, you have to wash your hand. Okay, or you clean your surface that you are regular touch, like top of your table, the handrail, doorknob. So all this you clean to prevent the transmission. Okay, next chain that you can tackle is actually the means of entry, where you block the entry of the virus to your body. Okay, so one, that because it's a form of respiratory disease, it's come through your respiratory system, through your nose, through your mouth. So that's why we wear a special mask, which is N95 mask. N95 mask is the only mask to actually block the virus to come to you. Okay, or you can wear a cover, yeah, uh, where to prevent splash to your eyes. For example, in a clinical setting, if you are handling a patient, you don't want patient cough or spit on your face, you have a face shield, and then you also wear a 95 mask and 95 mask. So that is actually to tackle the means of entry. And then the next part is actually the tackle the host itself, ourselves. We have to build our immunity. You need to be at our maximum health as possible. Try to eat a balanced diet. Make sure you have a balanced meal, that you have all the vitamins that needed in your body take. And also, addition to it is actually to take a vaccination to improve your immunity to fight the virus. Okay, so that's a way of controlling the disease. But what happens if we fail to control? Yeah, we fail to perform the prevention. Then we have outbreak to occur. Yeah, in our area. So what is an outbreak? Outbreak is an epidemic that is occur when we have more cases of disease than expected in a given area, or among a specific group of people, or in a particular period of time. So simply, if you can look at the graph in terms of number of cases over time. Okay, the first term I want to introduce here is endemic. Endemic means the usual prevalence of disease within a given geographic area of population. Means that the disease occur all the time throughout the year. I think in Malaysia now, what we can see is dengue. Yeah, dengue is occur all the year. So we say it's endemic. But if you have increase in the number of cases in certain area, let's say you have higher or double or triple number of dengue cases in, let's say, in one area in Selangor, you can say there's an outbreak in that particular area. So there's epidemic there. So or you can, what we can see now, there's increase in the number of COVID-19 cases in our country. So we have epidemic or outbreak of COVID-19. But if this epidemic occur worldwide, then we call it as pandemic. So what happened when we have outbreak? Okay, then the outbreak management. You need to manage the outbreak. The purpose of outbreak management is first to identify and control outbreak of infection. Okay, so that's what when you see that when we have a cases, you see that people do what we call a contact tracing, identify who are the close family member or friend who in contact with the case, and then we ask the person who in contact to be in quarantine, and then we monitor their symptom because we want to detect the disease early. So because if we can detect the disease early, we can control the further spread, we can prevent further spread, and then actually we can reduce the complication of the illness, because any disease, if you detect early, it will become less severe compared to if you detect at the late stage. So, and when you perform this activity, it's actually help you to plan what is the future prevention strategies. Okay, you know that by performing contact tracing in certain way is a better way of doing it. You can, because as times go on, you will improve what is actually lacking in terms of your management. So, and then you can plan what or improve your strategies in handling the problem, and then you can evaluate what you have done, and also most importantly you want to need to address public concern, whoever surrounding area, what are the people concerned about the disease. Okay, that's why you see that at the early of the outbreak, we have a daily reporting of cases from the MOH to answer the public concern, to report what are the situation, so that we want the public to understand, and also we don't want the public to panic or anything. So when we talk about outbreak, it's actually been managed at many level. You at the district level, okay, at the state level, at the national level, or in fact in a lower level like in hospital level. So what I'm going to share today is actually my experience in handling outbreak in our hospital, UniSZA Malaya Medical Center, because as you know that UMMC is actually a designated COVID-19 hospital. So we have our COVID-19 task force team that set up even as early as the first case that we have. In fact, before that we have a case in our hospital, also we already set up the team. And actually, UMC is actually a tertiary teaching hospital. We have about more than 1,600 bed with more than 40 specialties or subspecialties in our hospital with more than 8,000 staff. And we serve more than 1 million patients per year. So it's quite a busy hospital in a Klang Valley area. So this is the overview of our hospital. So this is what we function normally before the COVID. We have our trauma and emergency building. We have our RUCA building, which is our primary care medicine, and we have our pharmacy here. And then this is our main tower where we have our medical and surgical cases here. And then the south tower, we have other specialty like rehab, sports medicine, endoscopy, neurology, cardiology here, and biomedical imaging in this tower. And then this tower, we have hemato, the oncology here, diagnostic lab in here, and also we have a specific complex for the women's and the PIDS, for the PIDS and ONG cases. So when we have the outbreak or the COVID-19 comes to our hospital, we need to somehow manage or rearrange our function. So what we do, we have to make sure that in the trauma or emergency department, we have a section where the COVID-19 area and non-COVID-19 area. Same for the RUCA building, which we split. One is for those which are COVID related and then non-COVID related. So for your information, all our staff will be screened in this area, and all the patient will be screened in the A&E section if they come to our hospital. And the menara utama is actually we put especially for COVID-19 and pneumonia ward, because you know pneumonia, because some of the case they presented with pneumonia later on, then we noted that they actually become actually a COVID case. So we put we don't mix, yeah, we separate the ward. But for this tower, we have a section for COVID-19 ward and also pneumonia ward, so that if anything, we can easily transfer the patient from pneumonia ward to COVID-19 ward. And then we have moved all the non-COVID to one tower, the Malaya Selatan. Okay, all the medical and surgical in one side. In fact, when we manage the situation, we reduce all the bed capacity for medical and surgery, and then all the elective were cancelled. All the clinic also been non-urgent one. We defer the appointment of our patient unless it's really urgent, because we want to prevent any because when we have a COVID case, there's a risk is there of a COVID case in the hospital. We don't want to open the risk to other patients who come to our hospital unless it's actually necessary. So
Doctor,
yes.
sorry, I will give you like 4 minutes more
All
to
right.
wrap up for the first part
Oh,
before we
first
proceed
part.
with
Okay.
another guest
Okay.
speaker.
Okay. All right. So this and then for the woman and the child, okay, we have split into two section also. So what happened when we have when we treat a COVID patient, our staff actually exposed to the COVID case. So when we have our first COVID case in February, we start to have set up our surveillance system to monitor the staff who are exposed to the case. So we have this operation room where the aim is actually to rapidly identify the staff who actually might you have in contact with COVID patient. We want to assess them, monitor them, and we going to our team actually investigate the outbreak that occur within the hospital. So we have like main 4 division: contact tracing, risk assessment, surveillance, and the outbreak itself lah. So when we have a notified case, a contact trace team will be activated, perform the identified contact. Those who are in contact will ask to perform risk assessment, and then we will monitor them. Uh, and also we send a report, daily report to district health office. And if any outbreak occur, all a team will be activated to handle the outbreak. So this is our surveillance team that consists of our master student and specialist student. Okay, but as the times go on, the number of cases that we handle every day is not. It is actually the number of staff who been exposed. Yeah, increase. At one time, we have about 800 staff were exposed to a COVID case. So we can't do it manually anymore. So what we do, we turn the manual into automated system. We have to put in our staff portal. Where they actually can do a risk assessment online, where they fill in all the questionnaire, and then we will the system will automatically actually rate whether they are low, moderate, or high risk, and then we'll actually give the management straight away to the patient what to our staff what they should do, whether they should be in quarantine, whether they should go to take swab, or whether they have no risk, and so on. So if they are low, medium risk, okay, and high risk, they will put into a surveillance where we will send an automated system to remind them every day to update their status. Okay, once they fill in their surveillance daily, they will receive a response lah. If you have a symptom, and then we ask the staff to go to clinic to take the swab. So this all done automatically, and the admin can monitor in the dashboard. So it's all quite done quickly without to reduce manpower. So this is the status now. You can see that the number of those who are exposed to positive case actually been reduced. Actually correlate with what cases that we're seeing now. And this is the trend of our staff who are actually positive COVID. You can see it's also follow the similar trend that we see in Malaysia. And the peak in June, July, mainly because of the Delta virus that we see. Because when we do the lab testing, we identify that most of the cases it actually come from Delta variant during this period. So what happened during outbreak? Okay, we will investigate. We have a plan, and we follow up the outbreak quickly. First, we identify the linkage. Example here, we have a patient come in. First test was negative, so we put in the cubicle, but later on, tested become positive again. So they're exposed to another 2 person in the same cubicle and stuff. But also there are cases where unrelated occur at that period but exposed to their family or in the community and so on. So we really need to identify, is the linkage really there or not. And we also compare in terms of when they start their symptom, their infectious period and the incubation period to really identify the link between the cases. We look at the epidemic curve, okay, to explore what are the possible explanation of the situation. And we do a site visit to the location to identify, for example, any SOP breach, any flaws in terms of environment, anything that we can improve. Then we give recommendation to the place where they have the outbreak. Okay, so and we also monitor lah, for each location. We want to make sure that there's no further cases. So once after 14 days, there's no new cases occur related to the outbreak, we will declare the outbreak as closed. So we keep going on this monitoring. This is our team, and I think this the first part of my presentation. So I
All
will
right,
continue the second part after this.
All right, thank you so much, Professor Rafdzah. All right, we have not have much time, so let's just proceed with our second guest speaker from Singapore, Professor Alex, to share with us on how Singapore tackled the situation and COVID-19 outbreaks. Professor, we have like until 3:40 to finish your presentation for the first part. Right, the floor is yours.
Okay, thank you so much. Attempting to share my screen. Okay, great. So I'll be giving you a bit of an update on what the epidemic situation is like and has been like over the last year and a half in Singapore. For the first part of my session, I'll be kind of going up into almost the present, and then in the second part of the section, I'll talk a little bit about our plans for the future. It's probably a good idea to try to imagine whether you think Singapore has had a good epidemic or not, and then as you see the data, you'll get a sense of whether that was true or not. So I'm going to start off by talking a little bit about the epidemic situation last year, and then we'll contrast that later on to what the situation has been like this year. So Singapore government has been breaking down cases by type as a way to better understand the epidemiology. And I'm going to present it separated out into 3 different categories of cases: imported cases, cases amongst the general community, and then cases in our foreign workers, in particular those who are living in large dormitories. And I'll show you this over the 12 months of last year. So let's start with imported cases. This is the smooth version of the time series. We can see that there was a small rise at the very beginning of the year when we had imported cases coming over from Hubei before we closed the border to China. Then and unfortunately, sorry, we sent some of those cases over to Malaysia and caused some infections over there. Then we had a larger outbreak around about March and April, which was mostly caused by most Singapore students coming back, you could almost say fleeing from Europe and North America before international travel closed down. And then that led to a period where there was very little imported cases. And then for the last half of last year, we're able to maintain a fairly steady number, around about 10 cases a day being imported over the border, but handled for quarantine. Now, in the general community, how has the situation been like? So we had some small waves. I'm trying to, yeah, there we go. Small waves from the imported cases from China. But what really kicked off mass community transmission was actually imported cases over from Europe and North America. At that time, they were allowed to home quarantine. They weren't supposed to go out. And actually, there was quite legal restrictions to avoid them going out, but there was nothing to stop them from coming into contact with their family members. And so that led to quite a lot of spillover transmission from imported to into the general community. Now that was addressed by Singapore going into a lockdown, what we call the circuit breaker, for 2 months. And as you can see, circuit breaker was very effective in bringing down the number of community cases. Now the third group I'm going to show you is for foreign worker dormitories. So I'll talk a little bit more in the next few slides about this. The numbers are almost off the chart. Yeah, I have to have different scales for all 3. So we had huge outbreaks amongst our foreign worker dormitories, to the extent that actually we were running out of testing capacity to be able to test all of the cases. That led to a much longer period of lockdown for our foreign workers. In fact, even today, they still have very strict restrictions on what the foreign workers in dormitories are allowed to do. For example, they're only allowed out of the dorm a few times a week, except for work. So I want to highlight a few key messages from this. First, as I mentioned, imported cases predated the community surge. Lockdown was very effective in preventing community spread, but it made the foreign worker outbreak worse. Right? You can see the foreign worker outbreak accelerated after we started the mass lockdown. And I'm going to explain over the next slide why that would be the case. The final point I want to highlight is you can see that although we had a lot of spillovers from imported cases in March and April, actually the rest of the year, that wasn't the case. And so we were able to prevent spread from overseas into Singapore by having quite strict quarantine measures in place. And I'll give you some pictures about how that worked later. Okay, so I think that we can. So overall, 2020 was a fairly good year if you were living in the general community, but a really terrible year if you're one of our foreign workers. So what went on there? So Singapore had, I think, over 300,000 foreign workers living in dormitories. They, I think most of them live in formal dormitories constructed to be a dormitory for foreign workers. We have a large number of informal dormitories, so parts of factories which have been converted into a little bit of temporary housing for them. So these 40 or so formal dormitories, which are scattered around but mostly the outside parts of the island, can contain somewhere like thousands to 10,000 men. And the conditions are such that within one unit of this, there will typically be 10 or more men living. So to give you a sense, one of the dorms that I've been to, a unit would be the same size as my somewhat small flat that I live in with a family of 4. So that flat would have 30 men living in it rather than a family of 4 men. So that's the kind of the very high density living environment. And that led to, when they're not allowed to go out to work, and are not allowed to go out of the dorm, and not even allowed to go out of their room except to get food or necessary supplies. You can easily imagine how disease can spread very rapidly in such a dense population. Now, what really saved Singapore's butt in that respect, sorry, pardon my French, is that the outbreak in our foreign workers was extremely mild. So large numbers of infections, not all of which were diagnosed. We identified a lot of them through serology testing afterwards, but very few of them led to severe disease. You can see that less than 1% of those that we identified at the time due to the clinical presentation actually progressed through the ICU, and very, very few of them died. So over half of them infected, we only found about maybe 10% or so of the population to have been a clinical case, and a very small number of them had a severe infection. And that's one of the reasons why Singapore's case fatality rate, if you look at international comparisons, it looks really great because we had a large number of infections amongst fairly young men who are quite healthy. Okay, so what other measures do we have in the community to try to prevent spread? Because you've been quite effective, as you saw from the number of community cases a few slides back. So as with Malaysia, you've had various movement control orders and so on. So Singapore had an intense lockdown for about 2 months in the general community in the early part of last year, and this we call the circuit breaker. So during circuit breaker, schools were closed. Schools have mostly been open for most of the pandemic, but during that period they were closed. Workplaces were mostly shut. Shops were mostly shut. Essential work, such as your professor looking at COVID, you're allowed to keep on going into work. And if you are a restaurant, you're allowed to continue to sell takeaway food to top off, so you can take that back. But for the most part, most of the restaurants were otherwise shut. And you can see this Orchard Road. If you've ever been to Singapore, usually it's thronged with people, but it was extremely quiet then. What else do we have in place? So mask wearing, as we just heard, is an important part of preventing spread. So it is mandatory in almost all places. If you're at home, you don't need to have it. And if you're in an office, but you're the only person in the office, you're allowed not to wear it. So out in the street, you have to wear a mask. We've got vending machines you can get your mask from. masks have been sent out to all households in the country to try to make it easy for people to wear masks. What else? As part of our contact tracing, whenever you go into a mall or a restaurant or a shop now, you have to scan in with your phone or with a little device, and that allows digital contact tracing to be more efficient. And so MOH, if you turn out to be a case, they can find out who else might have been exposed to you through the places you went to. Similarly, on all of our phones, we don't even have to, but most of us will have an app installed to it, or at least have a digital device that they can have, which will send out Bluetooth signals to other people, and therefore, when someone is identified as an infection, we can extract out who they came into contact with, how long they were in contact with them, and decide who would be prioritized for quarantine measures. All until I think 1 or 2 weeks ago, all of our cases that were diagnosed were sent to either a hospital or healthcare facility for isolation. So we have not had home-based isolation, although I'll mention later that we now implemented that. And so this is a conference hall which was converted into a temporary hospital at the peak of our foreign worker outbreak. And then I mentioned already quarantine. So we have quite strict quarantine when you're flying into the country. For most origins, for most countries of origin, they would be put in a hotel for 2 weeks. And lucky guys get into a nice hotel like this. And for lower risk countries like Brunei, for example, or New Zealand, then they've been able to avoid hotel-based quarantine and skip past it because the risk was considered to be quite low. Okay, so that gives you a sense of where we were at the beginning of the year. Community transmission, relatively well managed. Foreign worker outbreaks, not that well managed, but at least didn't spill over to general community. Okay, so how are things looking like in 2021? I'll show you again the 3 groups, and I'm going to highlight a few things. So one is that we started vaccination at the beginning of 2021, and by now, just over 80% of the population have been fully vaccinated. About 90% of the population aged 12 plus. I'm also going to indicate the Delta era, right? So from April onwards, almost all of the isolates that we've sequenced have turned out to be the Delta variant and not the original or other variants. Okay, so let's go through the cases again. So imported cases, you can see we had a bit of a rise at the beginning of the year, and that has been fairly low lately. Okay, the general community. So compared to last year, we're getting a lot more cases in the general community. And in fact, even now that we've got a large fraction of the population vaccinated, we're off the charts. In fact, yesterday's data was over 1,000 for the first time in the general population. So I'll talk a little bit in my second part of my talk about why that's the case. Foreign worker dormitories, we have had lately a little bit of a rise, but for the vast majority of the last 12 months, we have had almost no transmission in the foreign worker dorms, even though the conditions are not any better. It's still as densely populated as it was. So it looks quite worrying when you see these numbers, especially from the general community, if you live in the general community. But I want to contrast it with what we see when we look at severe cases. So if we look through the number of people who are currently warded in intensive care in Singapore, I'm going to show you how that has changed over time. But I don't have data for the very beginning of 2020, but the big-ish outbreak, where it reached about 50 cases a day in the general community, around about the time that we went into lockdown, had about 30 people in ICU at the peak. We are currently at somewhere like 12 or 15 cases in ICU. So despite the fact that we're having huge numbers of community cases, we're not seeing a lot of people in the ICU. And why would that be the case? Firstly, the capacity is we're well below capacity. The capacity is 300 ICU beds for regular ICU beds, and we can, at a stretch, we can get up to 1,000. So the reason why we're doing so much better than what we would look like based on just cases alone is that the severity of the cases is much lower because we've been vaccinating. Okay, so I've got a couple of minutes. So there's 3 main changes this year compared to last year in how we're controlling the pandemic. And I'll talk more in the next section about what we're planning to change going forward beyond that. So the first is vaccination. So clearly that has had a big impact, not so much in transmission, but at least in preventing severe disease. The second is that we have had more phases of restrictions than what we had last year. So there's been quite a few instances where the government has turned up the control dial to like reduce the number of people who can go to restaurants, or reduce the number of visits that you can make to other people's houses. And so you can see that reflected in some of the digital data that's collected by Google and Apple, that in May, we had a drop in the amount of people going outdoors and a rise in the number of people at the home. And then again in July, when cases were going up again, we had a tightening, and then that led to more people spending time at home instead of going out walking or work. So that's one of the measures. Now, the last one that I want to highlight is that we have substantially ramped up testing over the last 9 months or so. So last year, testing was mostly PCR. And for example, here's one of our foreign worker dormitories. You've got the foreign workers lining up. They're going to be doing a once every 2 weeks PCR test. Now we alternate PCR and antigen. So they'll get a PCR test 1 week, then antigen test, which is quicker and cheaper. You can buy it at the supermarket for 1 year. And then it would be done every alternative week. We're also rolling this out to other populations. So for example, our healthcare workers also go through regular testing. And even in the universities, we've all got an app. You want to be on campus, you got to have this UniSZA app on. And as part of that, we're supposed to do fast and easy testing. So once a month, because I'm vaccinated, I'll need to take an antigen test and upload it into the app to show that I'm not currently infectious. If I had not been vaccinated, I would have to take this once a week. Right? And so the idea then is that we'll be, by having more frequent testing, we'll find cases earlier and be able to get them to isolate earlier. So in the second part of my talk, which I'll talk about after Dr. Yodi's presentation, I'll talk about what we're expecting to happen over the months ahead, given that we're seeing this large rise in the number of community cases. But I'll stop here and I'll pass over to Dr. Yodi. Thank you.
All right, thank you so much, Professor Alex, for your insights just now. It's great to see how Singapore handled the pandemic very well. I love the idea when Singapore have vending machines for the people buying their masks instantly. If we sometimes we tend to forget when we going outside, and then, oh, where's my mask, and then you can just buy it directly. It's a great idea. Okay, that's all from Professor Alex. Now let's move on to Dr. Yodi to share with us on how Indonesia managed this pandemic, the prevention of COVID-19, and also about vaccination program. So the floor is yours, Dr. Yodi.
Okay, thank you. Let me try to share my screen. Wait. Can you see my screen? Is it visible?
Not yet.
Not yet?
Yeah.
It's already on share screen.
Our technical team, is it the slide? Okay, we can put it on screen, or maybe you can just try again, Dr. Yodi, to share the screen.
Wait. Now can you see?
All right, I think so. Yes. Okay.
Okay, so good. Okay, so thank you for the invitations to share in this forum. So I'm going to share on the lessons or reflections from the COVID-19 pandemic in Indonesia. Apologies, I'm not going to divide it into 2 sections. I'm going to combine it into one, but it's going to be more or less 30 minutes as requested by the organizers. And I'm not going to go so much into the details of how the pandemic evolves in Indonesia, because just recently, a few days ago, we published our report for WHO, and it's you can download it on the WHO website. So I'm just going to go into a high-level overview of what happened from the beginning of the pandemic until now. So here's Indonesia. It's a big country, and as you can see, as you can expect, the distribution of COVID-19 is uneven, and it's mostly in a highly populated area, mostly in Java and Bali, while the rest of the country, especially in the eastern part of Indonesia, we have much less cases. Now, as far as the situation is, also in contrast to what's happening in Malaysia, in Thailand, in Singapore, I think the pattern is almost similar, that we all had an increase around June, July, and also similar also this is because of the Delta variants, and also perhaps Indonesia, because it also coincides with the end of Ramadan, the Eid celebrations, even though we had restrictions back then during at Eid, but after that there was some relaxation. Apparently there was quite a huge mobility of masses 2 weeks after Eid, and that led also to the spread of the infections around June and July. But as you can see in the graph, that peaks around mid July, and then it's practically going down, and we are now in a pretty good shape in terms of the wave. So we think we're pretty much over the second wave in terms of the cases, and also in terms of the death. Also here you can see it's pretty much going down. We're in a low level in terms of death. Our ICUs are also pretty much vacant. Our hospitals are also have a low bed occupancy rate at the moment. So with this kind of situations, people are, as the previous speaker also mentioned, are a bit more relaxed, and also some of the situation are a bit more relaxed. And even the government now is very much talking about transitioning to an endemic situation. Uh, Thinking that perhaps that this is we are more or less over with the waves, and we are moving to normalcy, and that COVID-19 is going to be more of an endemic rather than pandemic. And I think it was already mentioned or explained what does endemic means. Now, this is something which is quite worrying for us from academias, because we don't believe that this Indonesia is already entering into the endemic phase very soon. I just wrote this a few weeks ago, and it's basically arguing that we're still quite a long way from transitioning to COVID-19 endemicity, and there are many factors which shows that we're still quite a long way, and that could be up for discussion rather later on in the Q&A. But the point here is that the government, the community, and the public should not let the guard down at this moment. They still remain vigilant, even though the number of cases, number of deaths is pretty low at the moment. And we are hoping that it remains low. But it's still a far cry from actually calling it an endemic disease. So that's one point that what I would like to highlight coming out from Indonesia. The second point is that we might not expect another wave, but unfortunately there will be another wave, but not COVID-19 wave. We might expect a wave of chronic diseases. We might expect a tsunami of cardiometabolic diseases, heart disease, obesity, hypertension, and so forth. Because what most people overlook is that during the whole pandemic, there's a lot of disruptions in the general healthcare services. So here, this is a WHO survey round 1 and round 2. And they basically picked up that this is from Indonesia, that many of the services are being disrupted, be it primary care, emergency care, rehab care, reproductive, immunizations, non-communicable diseases, and so forth. And if you go into more details, for example, in terms of primary care, many of the health promotions and prevention services are disrupted, more than 50%. So that has quite a lot of serious implications when you have more than 50% of your general health promotion prevention services are disrupted because everybody's focused on COVID. You also have disruptions in terms of reproductive care. So here, for example, management of malnutrition is up to 50% disrupted. You also have disruptions of antenatal care, facility-based birth, and postnatal care. For communicable diseases, you also have disruptions, especially for the HIV. So HIV testing services, continuation of ARV treatment, initiation of ARV treatment, those are being disrupted. But what is most disrupted are the non-communicable diseases. So here you see also that services for hypertension, cardiovascular, cancer, diabetes, asthma, dental care, they're all being disrupted. So all of this have very serious implications, even though we might not have another wave of COVID, God forbid, but unfortunately we probably would have this tsunami of chronic diseases because these are not under control for the past over a year now, and the services are still not at the level before the pandemic. So that's another issue that we have to bear in mind beside in terms of transition to endemicity, which still quite a long way to go, but also in terms of anticipating this next wave of chronic diseases, which are more likely to be an issue than another third wave. And then another issue, which we think also is more important to keep in mind, is that this is not going to be in the last pandemic. We might see that COVID-19 might be going to endemicity, but there might be other pandemics because as in reality, we are in the age of pandemics, and that the world is also far from equipped to prevent or stop the next pandemic. So we think that this is high time to actually reflect on the lessons from the COVID-19 and to see how we can be better prepared for the next pandemic. So these are just some of the reflections coming out from Indonesia on how to actually better prepare for the next pandemic for the country. There are some issues we need to think of, which I will go into a bit more details in the next few slides, ranging from how to enhance the warning system, how can we better have data-driven decision making, communication issues, public health measures, ensuring access to vaccines and medicines, and also fostering social innovations. So for the first one, it's about surveillance. So it's about how that we can actually detect all of this potential pandemic earlier rather than later, because everything starts with surveillance. If we don't look, we don't see. If we don't see, we always respond too late. And that is one major weakness in our system here in Indonesia. When the pandemic strikes in early 2020, there is only one lab in Jakarta which is designated for COVID-19 diagnosis for PCR testing, while the rest of the country did not have that capacity. So we did not have that capacity to actually confirm the cases in the early days of the pandemic. Now we have a network of labs which can do that. But now there's another problem. Now it's not just detection by PCR. Now we're talking about genomic surveillance because of all these new strains. And that we still lack the capacity as well. We don't have that capacity comparable to the UK, for example, who is doing a lot of genomic surveillance, genomic testing. And that is also something which is of concern because now we see all of these mutations coming forward, and yet we don't have that capacity. So most likely there are mutations in the country which we will not be able to pick up because of our capacity to actually detect them early on. So that's one issue which we need to work on if we want to improve our preparedness for the next pandemic. It's about improving our surveillance, not just the usual surveillance, but particularly, for example, genomic surveillance, and also to bear in mind that most of this pandemic, I think around 70% are zoonotic diseases coming from animals. So also the challenge is how to be able to do surveillance among the interface between human and animals, which is something we're also lacking. So that's number one, strengthening surveillance, genomic surveillance, but also surveillance, the interface of human and animal. Second one is about data. And so this is also one thing we are not very strong on in terms of data analytic. We have our data is very poor, so it's very difficult for us to actually make projections, estimate. We in academia often are requested by the government to make mathematical modelings for different interventions, but it's very difficult for us to produce that because we know the data that we get is very unreliable. So that's also something that we need to work on. If we want to be better prepared for the next pandemic, then we need to improve the quality of the data, but also to improve the capacity to actually analyze data, big data, analytic, and so forth. That's something which we need to work on as well if we want to be better prepared for the next pandemic. Third one, I think this is happening in every country. It's about the infodemic. It's about the disinformation, misinformation, which is making things very difficult, and most likely it's just going to get worse in the next pandemic. Yeah? And it's very rampant and it's very difficult to manage because it's out there in the social media, and it's so we need that capacity to manage infodemics, which we at the moment we don't have much that capacity. It's something which is very new to us, so we were not in a good position to actually manage this disinformation, misinformation, these hoaxes which are everywhere and making things very difficult to handle the pandemic. So that's a third issue which we need to really work on if we want to be better prepared for the next pandemic, is that to build our capacity to manage infodemics before the next pandemic strike. Fourth issue is about public health interventions. There were a lot of talks in the previous presentations about lockdowns. We never actually imposed any strict lockdowns in Indonesia. In fact, the government avoided any strict lockdowns in any parts of Indonesia. They imposed what they called more of social restrictions, which are very mild compared to what we're seeing in Singapore or Malaysia. And one of the issue there is an issue more of economic and political pressures which the government has to deal with. And that comes also because of the issue of the disparity of the inequity among the Indonesian populations. So there is a wide disparity in terms of socioeconomics. A large portion of the population works in the informal sector, and they really rely on day-to-day revenue, on day-to-day income, not on monthly salary. So if they don't go out to work, they really don't get any money, and the government has very limited resources for any social assistance. So that makes things very difficult to actually impose any strict lockdown. And because many of these people won't be able to adhere or comply because they have to live, and there is not much means, not much alternatives for them to count on if they really have to stay at home for extended months. So that's also an issue which we need to work on. It's about equity. It's about improving equity within the populations, especially among the poor, the marginalized from the population, which have difficulty in terms of adhering to many of the recommendations of social distancing, of also trying to refrain from activities and so forth. While the middle class, the upper class, they don't have so much of an issue, but in the lower income families, this is something which is very difficult. So this is something which will become worse if we don't actually put more effort in improving equity in Indonesia. And then fifth part, it's about the access to medicine and vaccines. And this is also a huge issue in Indonesia. And unfortunately, as we know, there is a big issue of vaccine nationalism, where a handful of nations, especially high-income countries, are actually taking the most share of the vaccines, limited vaccines which is out there. And that is making it difficult for countries like Indonesia to actually get enough supply of vaccines to cover the population that needs. So this is the share of people who receive at least one dose of COVID-19 vaccines. If you contrast between Indonesia, Thailand, Malaysia, and Singapore. So as you can see here for Indonesia, it's still less than 30%. Even though that's actually quite a huge number, if you see that we have more than 250 million people and you count 30% into an absolute figure, but still it's less than 30% of the population. So still a far cry from the target to be able to get into herd immunity. And behind that, there's of course a lot of issue. You have logistic issue, distribution issue. You have also vaccine hesitancy issue, which we can discuss. But again, it's also a matter of the supply, and a matter of the vaccine that we can get our hands on. So if you look at it at the global level, you see that most of the vaccines are indeed in high-income countries. So here you see, for example, in high-income countries, almost over 65% of their population is more or less vaccinated, while in low-income countries, there it's 2.1%. So that's a huge disparity. That's what the WHO was talking about when they talk about vaccine nationalism, which is really impeding effective response to the global pandemic. And on top of that, there are quite a lot of companies, a lot of people who are actually making money out of it. And that's a bit ironic. So if you look at Forbes billionaires list, the richest people in 2021, there are quite a few new billionaires who are coming from the vaccine industry. So here you see the list of people from Moderna, BioNTech, also coming from CanSino, Biologic. These are people who are profiting a lot from these vaccines, and because they're making huge profit out of these vaccines. And they are even promising the investors that they will soon hike the COVID-19 vaccine prices. And this is a bit actually unfair because we are actually paying market price for these vaccines, while in reality, if you look at it, their R&D, the recent development was actually funded by taxpayers. So in the US, for example, the federal government actually invested in the R&D of the vaccine in these pharmaceutical companies. So it's actually unfair that they actually then made to impose the price at the market level, because actually much of the risk in developing the vaccine was already taken out by government funding. And yet you see that the price of their shares, their stocks actually increased a lot once they have their vaccines already in place. So for example, there you see Moderna 56.8%, Novavax 769% increase, and so forth. So that is making things very difficult for low-income countries to actually get their hands on the vaccines. So that's why Indonesia is joining India, South Africa, and many other countries to actually advocate for a WTO waiver for intellectual property protection from COVID-19 technologies, including vaccines, because we don't think that there is any solutions to a global vaccine crisis without actually placing pressure on big pharma, including waiving this intellectual property rights and technology transfer, because it's difficult to ramp up the vaccine supplies unless we can actually produce these vaccines in lower income countries, and where there are actually some potential for manufacturing if they have this access to this technology, if the legal aspect allows it. And the last part that I would like to highlight is one part which is often overlooked when it comes to the pandemic response. It's about the society, about community resilience, it's about social capital. Yeah? So we see that in Indonesia, it plays a lot of role in terms of how the pandemic evolves, how the resiliency of the community. And here you see, for example, innovations at the community level, which was initiated by community. So here, one community in Bantul district, not far from where I live, they created a community shelters so that people can isolate there, because it's not possible for them to isolate at their homes, because their homes are inadequate in terms of, for example, maybe it's already overcrowded, but also because there is not much place also in the health facilities. So as intermediary, they have their village shelters, which is all community initiated. This one example have 19 beds. It has television, medical devices, and guard officer. These are for COVID-19 positive, which are with mild symptoms or without symptoms. And you also see community organizations moving into online. So for example, this is communities coming together to share information on the data for ambulance, because there was, during the surge in June, July, a lot of community were panicking, trying to be able to call an ambulance, and there's not many ambulance out there. So a lot of people were looking for information for ambulance. Also looking for guidance for managing the deaths of families or relatives. So here, for example, the community also facilitate corpse handling by community. And also in terms of economic activities. So here, for example, the community also tried to mobilize themselves to be able to help those in the informal sector to actually still have economic activities even though they're at home, by, for example, here, taking part in vacuum frozen packing. And you see similar innovations also in other parts of Southeast Asia. For example, here in Thailand, you have a community which are organizing themselves to set up community kitchen for vulnerable, marginalized populations, such as migrant population and non-religious communities. This is another one also in Bangkok, where people who are trained in organic farming, and they have vegetable plots in Bangkok, and they distribute these organic plants to a larger community free of cost. And that's duplicated also across other communities. So these are what we call social innovations in health, which we see more and more, and it's actually very important for the community to survive through crises and pandemics like this. So these are inclusive solutions that meets the end user through a multi-stakeholder community engaged process. And it's really well suited for the COVID-19 because it focuses on local needs, and it's for local solutions and builds on community strength. and it's in contrast with technical innovations, and we need both. But in most places, most settings, people are very much focused on technical innovations in new vaccines, new diagnostic, which is of course very much needed, but we also need the social innovations. And here you can just contrast them, that the technical innovations are very much problem focused. It's created in labs by experts, and it really outputs are new products or services, while the social innovations, they are not created by expert, they're created by expert and lay people, and it's not focusing very much on the problem, but more of the social challenges and unmet needs, and also more possibility focus, and they're created within the contextual reality, and they're usually more sustainable and durable. So these are the characteristics of the social innovations we see, and which are very useful during the COVID-19 pandemic. So these are innovation, it focused on local needs and priorities. And we also have ongoing community mobilization, which were adapted. So it was already there, but can be adapted for COVID-19. You also still have digital social innovations with engine COVID-19 communication. And you also see multi-sectoral collaborations through the social innovations. And there's also a strong focus on equity and people-centeredness throughout this successful social innovations. So those are the main lessons, main reflections in terms of pandemic preparedness coming from the ongoing pandemic. So it's more of thinking how to enhance the warning system, how to have a better data-driven decision, how to improve our public communication in the face of misinformation, how to strengthen our public health measures. And this is again talking mostly about inequity, and also how to ensure access to vaccine and medicine, and how to foster social innovations. And all of these are much needed because I agree with the statement that preventing a pandemic may not be possible. So being prepared at the end is the key. So I think that's it. Thank you very much.
All right, thank you so much, Dr. Yodi, for a very insightful information provided to us. Yes, I agree one point that about the lower income countries that couldn't get enough supply of vaccine. I believe that we need to have each country, especially lower income country, to have the privilege to able to create their own vaccines to be given to the community rather than just accept and waiting the supplies from WHO itself. Okay, so before we move on to the part two, let's just take like 2 minutes break for us to have a quick poll at our YouTube live right now. So this quick poll, we will have our participants to vote on what their thoughts and opinions regarding the future pandemic, which is optimistic, concerned, sad, or uncertain. So we'll see the quick poll first at the YouTube live chat box. Good night, technical team. Done. All right. Okay, for to our participants, there's already the quick poll. So just vote. What is your feelings about the future pandemic? Is it you feel concerned, sad, or even uncertain? Yes, because current pandemic, I believe I also couldn't expect what I want to feel about future. Like, is it going to be worse or is it going to be better? Is it we can get back to our normal life? We're still uncertain, right? So just vote, and when our 2 minutes break is up, we'll just move on to our second part. Okay. Right. Most of the people. A lot of people feel so concerned about the future pandemic. come on, guys. If there's anyone who wants to vote, just vote, because we'll see. Because obviously we will also ask our panels today for their opinions too. All right. I think our 2 minutes break is up. It's just a short break to let our panels like take a deep breath first, and then to continue our presentation today. So for the second part, we will ask for we'll ask Professor Alex. But before that, our organizer will show to us the statistics of current situation of COVID-19. If not, we will just directly go to Professor Alex to present to us about the lessons from Singapore, which is transition from pandemic to epidemic, and yeah, what we could do to prevent this pandemic from occurring again. The floor is yours.
Thank you very much. So actually, I had initially been asked to talk about why the situation was not getting better. I can't talk about that for very long because there's just a simple answer to it, and that is that we now have the Delta variant, and the Delta variant is so much worse than the original wild type from Wuhan, such that actually the wild type doesn't exist. The Delta is the wild type now. So the Delta variant is more transmissible. We estimate probably about twice as much. The vaccines are not as protective against it, and it has so rapidly overtaken all of the variants worldwide that I think that the reason why things are not getting better is because of that. And I'll give a little bit of explanation as to how that's changing what Singapore is thinking about in terms of where it's going. So as we heard earlier in Dr. Yodi's talk, we're kind of in this liminal state just now where we've had a pandemic and we're in the pandemic, but we're thinking about how we can move out of the pandemic and what that pathway is going to be like. I think that all countries have lessons that you can learn from. And I'm more familiar with the Singapore epidemic, so I'll be talking about, I think, some of the things that we've learned that might be of relevance to the other countries in ASEAN. Okay, so what are these lessons from Singapore? The first is about vaccination. Vaccination is not a panacea. We have mostly been using the Pfizer vaccine. So the main one is Pfizer. We've got a bit of Moderna, and then some of the more old-fashioned people using Sinovac. But I would say the majority of the people who've been vaccinated in Singapore so far have been with the Pfizer vaccine. And I think there had been an opinion amongst the lay people that once we got a large number of the population vaccinated with this, what's it like, the Mercedes of the vaccines, right? Once we got a large fraction of people vaccinated with this, that we could stop everything and go back to life as normal. And I think that doesn't quite account for what we know about how the vaccine works in protecting against illness. So from the studies that we've done in Singapore and have been done elsewhere, we seem to be arriving at a consensus that these vaccines are okay at preventing you from getting infected, but they're not great. And they're pretty good at preventing illness. So we're seeing quite a large number of vaccinated breakthrough cases, people who've been infected, but they have very mild symptoms. Maybe they're even asymptomatic, but because of the contact tracing, we find them when we go out looking for them. But that they are very good at preventing severe disease, so ICU admission or death. So we think that the risk of ICU admission since the start of the year, after rolling it out to the older age groups first and then down to the younger age groups, that has fallen from maybe about 1% down to 0.1% of all of our cases. And that's the protective effect of the vaccine. So we can't expect that we can just relax measures and have no epidemic. And in fact, what we've seen is that as we have started to relax, we're nowhere near back to where it was before the pandemic, but as we've started to relax measures, even in a highly vaccinated population, with 80% of the population vaccinated now, we're seeing classical exponential growth, right? I'm going to put an exponential curve on it. It's an exponential growth, right? And so that I think that for our neighbors who are not as far through the vaccine rollout as Singapore is lucky to be in, we shouldn't be expecting that once we're vaccinated, okay, that'll be life back to normal, because we can expect that we'll see something like this even in a highly vaccinated population. And we can think, if we go back to mathematical theory, those elegant maths formulations, we can see why this would be the case, given that the vaccine effectiveness is probably only about 50% at preventing infection rather than preventing severe illness. So for a long time, we've known there's a relationship between the reproduction number or not, which is the number of secondary cases in a fully susceptible population when you're not trying to do anything to stop it, and the final attack size after one wave of the epidemic, again, if you don't do anything to try to stop it. Right, so there's a slightly ugly equation there, but I'll show you what that means. Right, it means that as the reproduction number goes up, you go from very small epidemics. In fact, if the reproduction number is below 1, you won't even see large epidemics, up to almost the entire population being infected over the first wave. And I've indicated on this chart 3 different points corresponding to 3 viruses that we commonly come into contact with. So flu virus probably got a reproduction number of about 1.5 or so. The original wild type, SARS-CoV 2, had a reproduction number of about 2 or maybe a bit more than 2 from the early studies the Hong Kong Europe looked at for the early data from Wuhan. The Delta variant, as I said before, is about twice as transmissible. So we reckon that the reproduction number is 5 to 8 or so for that. Let's just say conservatively it's 5. So unvaccinated population not doing anything to stop it. One case will infect 5 people. Those 5 people will infect 25 people. Those people will infect 125, right? So it won't take long before it permeates the whole population. Okay, so the equation is important because it tells us how much we need to reduce transmission by if we're not going to have large fractions of the population getting infected. We need to get the reproduction number below 1. Now, if we have a vaccine which is 50% effective at preventing you getting infected in the first place, then you can reduce the reproduction number by 1/3 if you vaccinate about 2/3 of the population, which I think is close to where Malaysia's at just now. So that would be enough for flu to stop flu from causing epidemics. Right? You'd be reducing the proportion of the population infected after one wave to close to 0%. And against the original virus from Wuhan, that would be enough to reduce from 80% of the population getting infected, which is massive, to 40% of the population getting infected, which is still massive. Okay. But it's going to do nothing to Delta. Still gets, I mean, it's close to 100% both ways. Even if you vaccinate the whole population with a vaccine which only protects against infection by half, then you're not going to do anything against Delta. That would stop outbreaks of the original variant, but not against the Delta virus. So we mustn't be thinking that we can stop the Delta virus through vaccination. The only way we can do it is ongoing measures forever, or an epidemic which reaches herd immunity, which Singapore has had for foreign workers, but not for the general population. Now, this large vaccinated population brings problems as well as benefits. The benefits are you have a lot less severe disease, but the problems are that many of the methods that worked in an unvaccinated population don't work so well in a fully vaccinated or highly vaccinated population. So I want to indicate some of the methods that we were reliant on before, which are not working now. So the first is about contact tracing. We know that many cases, many people who are infected and maybe infectious are asymptomatic, maybe for the whole of their infectious period. And in the past, that was quite a small proportion. So it didn't really stop us from doing contact tracing. It stopped us from doing complete contact tracing, but we could still get away with the app. We could still find some of these people who could do a bit of testing around about them. But if we have 80% of the population vaccinated, like Singapore now does have, then so many of the infections that happen are going to be mild or asymptomatic. There's part of contact tracing. How are we going to find them? So we're ending up with large numbers of unlinked cases now, because so many of the people that are getting infected are vaccinated and getting mild symptoms. That's the first. The second of the reasons why I think that the key approach to controlling the pandemic that we've been using so far has been really strict isolation and quarantine. And we've shown from some of the simulation studies that my team have done that if you isolate in a hospital or a healthcare facility or community facility, it's a lot more effective at preventing household transmission and therefore preventing overall epidemic spread than if you do isolation at home, home-based isolation, which I think is a bit of an oxymoron, right? So in countries like the US, where home-based isolation is the rule, you get about 3 times more spread than in a country like Singapore or China, where that has been the exception and it's been institutional-based isolation. But institutional isolation is not going to work very well, or it will be politically difficult to achieve if 90% of your adults are vaccinated and have extremely mild symptoms and are now being told that they have to go into that temporary facility at the conference hall for 2 weeks away from their family, right? So adherence to all of the measures that we're looking for, right? We want people to come forward for testing, but if you're going to be isolated for 2 weeks, even if you got no symptoms at all, that's going to be something that many people will bite back against. So as I mentioned, we're in this kind of a liminal state now where we're trying to transition through into a new life, right? A life in which the pandemic is behind us, right? And so how are we trying to do that in Singapore? So over the last few weeks, the government's announced quite a few substantial changes to how we're going to be managing the virus as we stop thinking of it as pandemic and start thinking of it as endemic. And you can argue that some of these are risky. I'm not sure. I support the approach, and I'm not saying that because I'll get in trouble if I don't. But I think that some people in the community, especially in the ID community, are against it. Okay, so the major changes are isolation will now be at home unless there's a medical need. So everyone under the age of 70 who's vaccinated and is able to be isolated at home will now be isolated at home instead of going to hospital. We're reducing the length of quarantine because we know that the Delta variant has a shorter incubation period. And with so many people vaccinated, then we also think that if you do get infected, you progress through, you recover from it much faster. We'll have shorter durations of isolation. The most recent announcement from our Director of Medical Services is that if you test positive in an antigen test, but you're asymptomatic, take another antigen test in a few days, and if it's negative, you're fine and you can go back out to work. We're attempting to reach the last unvaccinated pockets of the population. There's small groups of people who didn't want to get vaccinated for some reason. In the longer run, we may be, I'm sorry, Dr. Yodi, we may be vaccinating our kids, our primary school kids. They get almost no medical benefit from it, but Singapore's got the vaccines and they feel that we may as well do it. We are also looking at doing boosters for the higher risk groups. For those who are immunocompromised, like cancer patients, for example, that we know that they probably are not receiving much benefit from the vaccine now, so they're going to be getting a third shot. But also older age groups, even though they may not need it, we're going to be giving third shots to them. Not sure about the ethics of that, but that's what we're going ahead with. As I mentioned before, we're going to have more rapid testing. I bought this in a pharmacy near my place. You can get it from vending machines now. We've got 100 vending machines around the country. I'm dispensing these. We're going to have less contact tracing, so we narrower in scope. Only around about the household or really high risk individuals would be told to be quarantined. Borders will be reopened to more countries, like Saudi Arabia, for example, and now gets to have really short duration of quarantine. And because we've got exams coming up, we're going to close schools for a little while because of that, so that the kids won't get sick during their exams. Okay, so I think that's a huge change in how we're managing it. And I expect that we're going to see more infections as a result of these changes. So here's my forecast as a sketch about what we're anticipating. The pandemic era, we're now going to be moving to the endemic era, but we're going to have an outbreak in between pandemic and endemic. We don't know how bad that outbreak is going to be, because we don't know whether we are at this point of the outbreak or this point or that point. Right? So we can't really say how far along that first really big community wave we are just now, because we don't know how many infections we're missing. We expect that most of the population will have to be infected before we can move through to the endemic state. And if we are there, right, and a large people have been infected already and just don't know about it, then that's great. It means that we don't have far to go and we'll get out of it soon. However, if we are, animate is great. If we're here, then that means that we've got a large epidemic still to go through, and that could lead to more severe cases. So if I can just skip past the animation again, sorry about that. I am not sure just now whether our ICU capacity will at some point be overwhelmed. And if it is, I suspect that the government will launch more measures, maybe another return to some form of lockdown in order to protect the ICU capacity. But we're now trying to orient away from cases towards severe cases. All right, and so that'll be what we're trying to count and try to prevent that from getting too bad to overwhelm the healthcare system. Okay, so Terima kasih, thank you very much for your attention. We got funding from our government, should say thanks to that, and it's my team that did all the work, not me.
All right. Thank you so much, Professor Alex, for the informative information for us. Wow. There are certain points that I feel like, okay, are we ready to enter the phase of pandemic, and then how the pandemics will going on in future? It's quite scared to just imagine that. Okay, but let's just now move on to Professor Rafdzah to explain to us about what are the lessons that we have learned from this pandemic, and what we can do to prevent a similar kind of pandemic from happening again in future. From your perspective, Professor Rafdzah, the floor is yours. Professor, you are muted. Please unmute. The mic. Okay.
Are you seeing the slide? No.
Not yet.
Okay. Okay, for my part, okay, actually when we talk about the lesson learned from the COVID-19, actually, in general, what been covered by Dr. Yodi and Prof. Alex, actually what's actually we experience in Malaysia as well. So in fact, in Malaysia now, we also actually going towards, like, we want to push for vaccination and try to go for looking for the endemic level, or because if we can achieve herd immunity is good, but the aim is actually to push for the vaccination, because what we can see now, from the what we see the cases is actually, of course, if you see the statistic, the number of cases is going up, but if you see the number of those who are actually severe cases is actually going down, because being working in the hospital myself, I can see the burden of the cases in the ward is really much less compared to when we have in July, in August, and the bed capacity, the ICU capacity is actually now is actually going down, with the severity that we seen is not as much as before. So we really put a high hope with the vaccine, and of course now with the higher number of vaccination that we have in the community, but with the increased relaxation in all the SOP, so we will still see a number of cases there. But as I mentioned, the most important thing is actually the number of severe cases, because that actually will help the health services a lot, with the number of medical staff that we have, with the number of bed and ICU staff that we have. I think compared to like a few months ago, even in PPM, we almost like 100% of our bed capacity in ICU also, where in fact some of the hospital they have to double their capacity. We have to open like extend the ward outside of the hospital because of the number of cases that need to be treated in hospital is increasing. And the situation now in hospital, especially in the Klang Valley area, when we have high percentage of population being vaccinated, the situation in the hospital in the Klang Valley is actually much better now. Okay, so and in terms of SOP and procedure, I think what you can see now, we start to relax the MCO. We also going towards home isolation, and we promote the self testing in the community. So I mean, if you look at the um, what is given, the instruction given by the Minister of Health, if you are tested positive, if you don't have symptom, you don't have to go to hospital. You just isolate yourself at home. So only call for help if you have a symptom. So now with the majority of us being vaccinated, we are quite confident that most of us actually will have a very mild symptom. So what actually beyond what happened with COVID-19 that I want to highlight is actually is what we can learn from COVID-19 is actually the importance of zoonotic disease in public health. Okay, why I highlight the zoonotic disease? Okay, because COVID-19 is one of a zoonotic disease. A zoonotic disease is actually an infectious disease of animal that can cause disease when transmitted to human. In fact, most of the disease, infection disease that occur in human, actually 6 out of every 10 of disease actually come from animal. Then 3 out of every 4 new emerging disease actually come from animal. So that's why it is very important to look back what can we do to prevent this from happening. Because if you look back in the century, this actually the history keep repeating itself. All the disease, all the big pandemic that occur actually all are origin from the animal. For example, a Spanish flu or H1N1 influenza is actually caused a 50 million deaths in 1918. We have a West Nile virus in US. We have Asian flu with more than 100,000 deaths. We have Hong Kong flu. We have Ebola virus, H1N1, even HIV also is a form of zoonotic disease, which is still we've seen HIV also until now. Okay, and we have Nipah virus. Okay, swine flu, SARS. Okay, SARS, the first SARS that we have in 2002, MERS-CoV. Okay, and now we have COVID-19. So what we need to take a lesson from this, actually all this disease that cause pandemic or big pandemic is actually come from the animal or from the wildlife. So we have to do something about this. Okay, because actually this pathogen or virus, they are evolved with the animal. They occur within the wild animal as a natural host. So and many animal act as their reservoir, and they don't have any symptom because it's actually naturally occur within their own body. So this is just to show example some of the diseases. Yeah, I already mentioned before also. I mean, this virus actually come from the animals and then it's go to another animals as before it's go to human. Yeah, we have Hendra virus, Nipah virus, SARS, and so on. So what is actually we need to know is the balance between the agent or the virus, the environment, and us a human or the host, because when the infection occur, it actually will affect us as a human. But what we want to take care is actually the balance between the environment, agent, and the host, and the animal who actually act as a reservoir and also as the vector. For example, we have a rabies who actually come from a dog that transmit to human. We have a mosquito as a vector for dengue. So all of these diseases, zoonotic diseases, is actually originate come from animal then become a threat to a human because of the imbalance between these three factors. So I just want to show a few example what happened when we have the imbalance between the three factors. For example, when we talk about the human population, yeah, we are increasing in the human population, growing, expanding. So because the increased number of population, we are exploring a new geographical area. So when we're doing this, as a result, yeah, the more people live in close contact with the wild and domestic animals. So this close contact provide a more opportunities from a disease to pass between animal and people. Okay, and then another example, the Earth actually has experienced changes in climate change. We know why we have a climate change and this land use is because of the activity among our human as well. You know, we deforestation, intensive farming. So all this actually cause a disturb to the environment, the earth, and also impact the climate. So this disruption in the environment, the animal habit in the world is actually provide the opportunity for this disease actually inside their origin, the wild animal, to pass to another animal and pass to human. And another factors is international travel and trade. Okay, this is of course is we need to have international travel and trade, but this is one of the factors that can result in the disease spread fast across the globe. So I just want to show the video how quick is the COVID-19 spread from its case, first case in Wuhan. Within like a few days, it's already spread all over um, continent in the world. So uh, of course, we can't restrict the mobility of the human, but uh, what the important thing is we need the first case happen is need we need to detect early when I think Dr. Yodi mentioned about surveillance. So that's you need to have this surveillance put in place. Okay, not only surveillance among human, but because we know that most of this pandemic disease come from animals. So the surveillance among the animal and the environment is actually very important. No, where we can have this an alert. So when something wrong happen in the environment that disturb the animal, and those actually the expertise among wildlife vet, they have their own method of doing a surveillance of disease in the animals and the environment. So if the alert from them to the human health, so this actually give us opportunity to prepare early, because we know that what's the threat coming before this disease hit the human. So here just to show the example how the interaction between human and animals over the time that's actually resulting in many newly emerging disease actually affecting us. So like million years ago, the relationship between human and animals is basically there's no relationship lah. All the wildlife, human as a hunter, you know, so mean there's no close relationship. So the risk of the virus inside the wild animal to jump to the human is very rare. So we don't see that many new disease at that particular time. Then when the times goes by, okay, we start to have companions, we have pet. So the interaction between animal and human is close. Okay, even though that let's say cat and dog might not have that, do not harbor the this dangerous virus, but this animal, you know, might have exposed to another animal that might uh, bring the virus then transmit to human. Because what happened once the virus jump from one host to another or one from animal to another, it's mutate. So maybe from let's say from the bat to human, it will not transmit directly, but what happened, it will jump from one let's say from bat to another uh, animal, either a pig or camel, you know, or dog. So this mutation occurs so that the virus can live in human. So and this mutation go on. So then later on, as a human, we have a agriculture. We have a big farm, livestock. So this again make a close contact between human and animals. And then what happened like in Wuhan with the COVID, like we know that this source start from the wet market, where that they have all the animals together in one place. They have the wild animals, all the snake, bat, and so on. So when all these animal in the nature of the origin, they are not actually close to each other. So but when all of them put it together, so this virus is actually changing, and that's caused the mutation that's actually trigger the virus to jump from that wild animal to another host, then lead to exposure to human. So that's actually uh, uh, make our as a human put at higher risk of having this new emerging disease. And now at present we have maybe the industrialization, how we actually change the um, uh, our agriculture, all the technology. We have been experimenting with the animal, and also with the lifestyle of like having exotic pet, exotic food. All this actually make the relationship between animal and human, and also the wild virus actually close to us, that make put it as higher risk of having a new diseases. The problem is when we have a new virus, because we don't know that virus well, that actually lead to an outbreak and might lead to a pandemic, what we have now. So what the key message that I want to highlight here, that these emerging zoonosis are a threat to all global health. As I showed earlier and before, you seen that each every few years we will see new disease will come in. Yeah. And as we can't avoid global trade, we can't avoid traveling across countries. So this is make the transmission or spread much even faster than before. So for us to understand all the aspect disease transmission and its factor, we need to work together as a what we call one health. Those from the human health, the animal, the environment, all need to work together, especially in terms of like a data or surveillance. We need to share all the information, so that we can utilize this information as like an early and alert to us to take action, so that we can prevent any future pandemic. Of course it's difficult to do, to work together from a different area as a team. It is a challenge, but this is something we need to work on. I think in Malaysia, the first time when we start to think about One Health is actually when we have our Nipah virus. Yeah, I mean, everybody actually worked together at that time. And then when we have the rabies outbreak also, that's where we work together. But I think when we see this COVID-19, I mean, the impact is to as a global health impact. So that's highlight again very important for us not to work just within our own comfort, our own area. Like myself as a human health, I need to work together with other colleagues in animal health and environmental health, because all this prevention occur of this disease before it enter human. Yeah, so we need a multi-sectorial collaboration. All the scientists, the ecologists, even the economists, and also those in the education. Because when we want to talk about disease, we want to talk about prevention. Those who want to giving education to the community, to the public, this the expertise is from the education, those from the maybe the psychology. So all the experts need to be in together, work together as a one health team, so that we can prevent this pandemic, something like this repeating again in future. Okay, that's the main highlight that I want to stress. And of course, another thing that what happened in Malaysia, I want to say that never celebrate too early. Even a moment can change your life. So what we happen, what we see earlier, we were so proud that we're managing the COVID very well. We handle the situation very well. We so say that we are among the best country who managed the COVID-19. But see, we celebrate too early. We want to we ease all the restrictions so early, then we have to face the consequence lah. Like this quote say, many games are lost because of overconfidence. So we are overconfident that we are actually already handle the COVID-19 over. So even now, we still need to continue all the prevention measure. Yeah, even though we say, okay, we only see mild cases, we don't see much more severe cases, but this virus, they keep mutating. We never know, at the moment we say yes, okay, even though Delta is maybe is much more transmissible, okay, but at the moment maybe we don't say that in terms of severity is not as uh, uh, is not as bad. So, but we never know. So we cannot take things easy. We still need to work together. Those with the lab, they need to continue monitoring the progress of the virus mutation. We need to work together with the um, other parties so that all these prevention measures still going on. I think that's all from me.
All right, thank you so much, Professor Rafdzah, for the informative information for us just now. Yes, I really agree with what Professor Rafdzah said that we need to increase more research and collaborative with the zoonotic areas, so we could like know what we can do, research more on how to prevent the virus from animals to go to humans. So we would not like experience other virus in futures, because I really hope this is the last virus from animals, which is COVID-19, is not more other more virus in future. So yes, I think the increase in research of in genetic area is very important. All right, so so before we move on to next part, if any of our participants have questions for our panels, please just drop your question on the chat box, YouTube chat box. So we just can just maybe pick one or two questions to ask to our panels. So while waiting for the question from our participants, I would love to ask a brief explanation from our panels today. We will start with Dr. Yodi about because just now we have done a quick poll in YouTube to our participants on what are their feelings about the future pandemic, and most of the participants has voted that they are very concerned. So maybe from Dr. Yodi's perspective, Dr. Yodi's feelings about what you are hoping for the future pandemic. Just a brief explanation. Back to you.
Okay, thank you. Are you referring to the next pandemic, or okay? I'm assuming we're talking about the next pandemic. Yeah, I discussed it already in the presentation. But one thing that I would like to highlight why I'm not so optimistic also about the next pandemic, that we are not well prepared, is also because there is a lack of solidarity at the moment across the countries. So we are in the same storm, but we're not in the same boat. I mean, there are countries we are now on cruise ships, but there are also countries which are now in lifeboats, but there are also countries which are in paper boats. And this is not going well for a global pandemic. So it's like every man for himself. And that's not something which is going to work in a global pandemic. This is, I think, one of the most important lessons for this pandemic, and which makes me worried about the next pandemic as well. As long as we don't have that solidarity up front, we're not going to get through, and we're not going to prevent the next pandemic. That's all, Fatih.
All right, thank you so much, Dr. Yodi, for your comment. Yeah, I truly agree too with Dr. Yodi. I think the main point, yes, the lack of solidarity is, uh, are we uh, are we really prepared for other pandemic? Of course, that's why it's very important for us to have like a good crisis plan, because this is global crisis. So we need to have a proper plan to manage this pandemic well, so we do not have to confront another pandemic, other virus, and this also the continuing of this pandemic COVID-19. So I will just ask the opinions from Dr. Professor Alex about what is your opinion on the future pandemic. Your brief explanation.
So I think that we had a chance to avoid this pandemic. Back in January or February of last year, if other countries had followed suit and done what China did, right? The mass lockdown. Everyone looked at it and thought, wow, that could never happen in my country. We can't do that. And a few months later, all all countries around the world pretty much were locking down. But if we had synchronized that and we had all done that at the beginning, then there's a chance. I mean, maybe we wouldn't have pulled it off. Maybe there'd be some misinfection somewhere that would emerge out. But in principle, we could have avoided that pandemic. Now, in practice, I don't think that was ever going to be the case. You had people like Donald Trump in America. We still have Boris Johnson in the UK. There's people like Orban in Hungary and so on. There's populists around the world who are always going to be thinking of their country first. And the problem is that spoils market, as we say in Singapore. If you've got someone like Donald Trump in charge of the US, then other countries cannot rely on solidarity because you know that there'll be someone who will break ranks, right? And so I think I would love it if all countries could have that solidarity with each other. But you just need one bad apple, and the whole basket gets wasted, and everyone's got to be thinking of themselves then. So I'm also not optimistic about the next pandemic. I really cannot see a situation in 10 years' time, 20 years' time, when we have the next big one, that we'll be able to coordinate globally and get everyone's interests aligned. Over.
All right, thank you so much, Professor Alex, for your opinion. So now let's move on to Professor Rafdzah's opinion.
Yes.
What is your thing? Your thoughts about
Okay.
future pandemic?
Thank you, Fatin. I
It's a
agree
brief
with
one.
yes, I agree with Dr. Yodi and Dr. Alex. I mean, with the situation, especially with those countries who actually really want, of course, they want to protect their own people. But as I mentioned, all this traveling trade occur across different international travels. You can't avoid, even if let's say you can protect your own country, but of course there will be a traveling occurring between one country to another. So if your neighbor have a high cases number of disease, even though your own country have zero cases, at any one time you will get the disease come to your country. So that's why you can't really just protect your own border. You have need to look at collaboration between multi country to make sure that this being handled at a global level rather than just their own country only. And when you mentioned about Fatin, we hope we are not going to see any new viruses in future. Actually, we will see new virus in future. That will definitely will see. There are many of them, but we hope that we don't see is actually a pandemic among the human, the infection among human that we see now lah. Yeah.
All right, thank you so much, Professor Rafdzah. Oh, okay, so it means that we might encounter another virus, but yes, we really hope it doesn't like become a pandemic just like COVID-19. It's just like in a locality or in a community.
Even though we don't want any outbreak in the local,
Yeah,
because virus
yeah.
is always there. You will have a new virus, but we want to prevent that virus causing an outbreak or worse,
Yeah.
causing an epidemic or pandemic.
All right, thank you so much, Professor Rafdzah, for your opinion. Okay, so we have like one question from our participants. Okay, from Legulit. I hope I pronounced the name right. Okay, so good afternoon, Prof. Does drinking water help in preventing infection? Okay, can I just give this question to Dr. Yodi to answer it?
Well, I think it was already outlined by the presentations before. What is preventive measures? And I mean, drinking water is good. I mean, it's good for your health, but I don't think it falls into the intervention or preventive intervention in terms of COVID-19. I mean, it helps your immunity, it helps your immune system, but it's not something which we would recommend as a preventive interventions for COVID-19. I don't know if others would have to add for that.
All right, thank you so much, Dr. Yodi. So we have another question from our participants. Okay, so from Harry Wandi. Okay, he asks, what's the action taken by the government, healthcare, and any related sectors in handling the misleading information regarding the vaccines and that rapidly spread within community through which is social media? So maybe Professor Alex could answer it.
Okay, I'll give it a shot. So I can talk in the Singapore context. Singapore government has a law which allows them to require any social media provider like Facebook, etc., to issue a correction to anything that they think is not true, and to have a post by the government explaining why it's not true. So that's been used a couple of times. There've been um, a few false online media stories about someone dying after they get the vaccine, and I mean no nothing is completely risk free, but in these cases the stories were not true, and they were brought down. I'd like to contrast that with the situation in Hong Kong. Hong Kong's got a much freer press at present, and in Hong Kong the vaccine uptake rate has not been as good as Singapore. They've got surplus supply and people have not been coming forward to get it. I think that's partly because whenever there has been any severe adverse reactions, they have been publicized quite prominently in the mainstream media. And because in Hong Kong there's not as much trust in government as Singaporeans have towards our government, that has led to a lot more vaccine hesitancy, and it's been harder to overcome that.
All right, thank you so much, Professor Alex. So I hope Mr. Harry, the answer provided by Professor Alex have answered your question. So okay, now it's 4:40 p.m. in Malaysia. So we just move on to the next session. Or we have another questions for our panels. If not, oh, we have. Okay. Okay, I think this is the last question. Okay, so from Duhul Media, he asked that some countries has a low rate of COVID-19 virus among the community, for example, in Africa. Okay, okay, so it wants Professor Alex to answer, but I think because Professor Alex have answered, maybe what about Professor Rafdzah? Like
Okay,
a brief
sure. Yes,
answer.
I can comment on that. Okay, when you talk about infectious disease, what are the factors driven into this actually? Human mobility and also density. So if you remember the map that I showed you when they start with Wuhan, Africa is one of the continent where it's affected last year, because there's a mobility between the country to country is less, from other countries to Africa, and also we look at the density of the population of Africa is not as high as other countries. I think that's among the factors that actually make the number of cases in the area is actually low.
All right. Thank you so much, Professor Rafdzah, for the answer. So I hope Mr. Harry, Mr. Harry, no, Mr. Duhul, the answers given have answered your question. Okay, now let's move on to the most awaited part, which is the quiz session. So for quiz session, we'll be using Kahoot platform. So the participants who are tuning in right now with us, please look at the chat box in the YouTube comments where our committee will insert the link, the code and how you want to enter the Kahoot platform for the quiz session. Okay. So we're waiting for the participants to enter the quiz session. We will see the montage video of this program. So please adhere to the rules, okay? Please enter your university and your name when entering the Kahoot platform. Alright, we have a lot have entering the Kahoot session. Keep on, guys. We give like 2 minutes more for you guys to enter the Kahoot session before we start. Make sure to join everyone because the winners will get amazing prize from our community. Alright, we can just start the Kahoot session now. Okay, let's just start. Okay, which country has the lowest number deaths per capita in ASEAN? Wow. So will it be Brunei, Laos, Malaysia, or Singapore? Oh, Laos. Wow. A lot answer Brunei. Why is that? Okay, we have participants from UniSZA, Lisa, got scoreboard. Let's move on to the next question. What is vaccination? Okay, yes, vaccine that protects you against a specific pathogens. Yes. Okay, let's move on to the next question then. All right. So next question for the first question. Okay, Professor Rafdzah, I think like if we are tested for COVID-19, so is it better for us like do home isolation first or go to the hospital directly or quarantine?
I think for the moment, like in Malaysia, what the instruction is if we are tested positive but very mild symptom or no symptom, then we can isolate at home with provided that we have all the facilities.
All right. Okay. So it's better for us if you are not having too much like mild symptoms, so just isolate at home first, right?
Yes, yeah. I think we see a different what happened in the early of the pandemic because the capacity and the number of cases is much less. What you see at that time, we all admit all positive case, no matter what are their stages, what are their symptoms like. But now with the very high number of cases, we can't afford to admit everybody. So, like what we are doing now, so those who are actually a very mild symptom, we are suggesting them for a home isolation. But actually, there are few facilities, hotels, they offer for those who are actually tested positive with minimal symptom for them to be isolated in the hotel rather than to be staying at home with the family.
All right. Thank you so much, Professor Rafdzah. Okay, let's move on to the next question. Ooh, Lisa is still on the top. Wow. Okay. So most of people understand that vaccination prevents most of the severe cases, but only a little protections against infection. Okay. So what is your opinion about it, Dr. Alex? Is it true or false?
Yeah, so from some of the household studies that we've been conducting, where we follow up household members of cases, what we are finding is probably about a 50% reduction only in your risk of getting infected, but that probably about a 90 to 95% risk reduction against severe disease.
Okay. Thank you so much, Professor Alex. Let's move on to the next question. Wow, I'm amazed with Elisa. She's still on the top of the chart. You can use alcohol gel to clean your hands if you do not have access to soap and water. Hmm. Yes, true. How come there is five people who answer it wrong? I think alcohol gel is the same with the hand sanitizer. Okay, so if you do not have an access to the soap and water, just always remember to bring your hand sanitizer so you can just sanitize your hands. Okay, so let's just move on to the next question. Which group of people has the most infection in Singapore? So Professor Alex, is it elderly or foreigners or travelers or children and teachers that most infection? Oh, it's foreigners. I think it's the same like you have presented just now, right?
That's right, yeah.
All right. Thank you. Now let's move on to the next question. Which statement is best to describe the incubation period? What do you think, Dr. Yodi, about this question? Which is the right answer?
So it's the time between when you contract a virus and when the symptoms starts.
Wow, it's the same answer with Dr. Yodi. I think if
Mm.
Dr. Yodi join this game, he also will get the correct answer for this and other questions too. All right, thank you very much. Let's move on to the next question. What is the main reason why Singapore is having a outbreak just now? Just now or right currently? So what is your opinion about it, Professor Alex?
I can't say just now because people are still answering. Yes, that's right. It's the Delta variant.
Okay.
Yeah, much more transmissible.
Oh, so is it just because there's a lot of people from outside Singapore is coming into Singapore, so it's
Very, very little lately.
okay. So it's make the Delta variant came into Singapore, right? All right.
Yeah.
So let's move on to the next question. People who already had COVID-19 may still need to be vaccinated. I think it's yes. Professor Rafdzah, Professor Rafdzah, what is your thought on this? Do you think like when who already affected with COVID-19 still need vaccine or not?
Yes, they do because in fact, if they have like a second infection, they might have like severe disease. So if even after they have recovered from COVID-19, they should get vaccination to give a much longer protection and protection from
Oh,
severe disease. Yeah.
yeah. So for those who have been infected with COVID-19, please also get a vaccine so you can protect yourself much better. Okay, let's just move on to the next question. Okay, we are second last question. The One Health approach is best described as the collaboration between. I think this have been mentioned during Professor Raf's presentation. If the participants paid really full focus on the presentation, so they would know the answer. Right. Oh, I think 14 people is a bit confused with the first definitions. Yes, it's actually between animal, human, and environmental sectors in zoonotic disease prevention. All right, so let's move on to the last question of Kahoot session. Oh, Lisa has gone down. We have Amirah now on the top. Currently in Singapore, the ICU numbers are. Oh, Professor Alex. What do you know? The
I know the
current.
answer because I asked the question. Yeah. I think this is probably not just the case in Singapore because we heard earlier that Malaysia also similar situation where the numbers
I
are going down,
see.
right? And in Singapore's
Oh,
context, it's still extremely far below the overall capacity of the healthcare system.
all right. Thank you so much, Professor Alex. So I think the quiz has done. So let's just see who are the winners of the Kahoot session. On the third place, we have UMK Farah S. Dot. Second place, UniSZA NEET. And the first place goes to UniSZA Amira. Congratulations to the winners. To the winners, please look at the chat box. The committee will post the person in charge for you to contact to redeem your prizes. So if you do not contact the person in charge, I might take the prizes on behalf of you guys. All right. So that's the end for the Kahoot session. I think okay. All right. So it seems like the sessions is already end. I would love to say endless gratitude to our guest speakers for being very cooperative and willing to share their knowledge and thoughts, opinions, and lots more with us today, and also with our participants. So we also hope that to our participants, you have gained a lot of insights today, as much as possible, and you know a lot of new knowledge about COVID-19 vaccination, and I believe also about I truly interested in the topic about zoonotic research or zoonotic area. So once again, thank you so much to everyone for gracing our program with your presence. We from the committee truly appreciate it so much. So now I would call upon our MC, Alpha, to continue with the next session. So that's all from me. Thank you so much. Uh, So to all participants, please follow all the regulations, rules by the government. Wear your mask, sanitize your hands, and take a good care of yourself. Okay, especially go get your vaccine. Okay, so that's all from me. Thank you so much. So Alpha, the floor is yours.
Thank you. Bye bye.
Don't leave yet. Okay, our guest speakers.
Okay.
What a great session. Thank you so much to Fatima Sar as our moderator for the session just now. My mind is just bursting with so much information, reminders and thoughts, and what an enlightening thought. And with this, we have come to an end on the webinar. A million thank you to our speakers, our moderators, and also participants and organizers for creating this initiative to enlighten us more on the topics discussed. So, please, I would also like to invite our director for this webinar to come to the screen as well so we could all take a little picture for memory's sake. Director, you? Hello, Mr. Director. All right, whenever you're ready. 1, 2, 3. All right, one more photo. Yeah, freestyle this time. 1, 2, 3. Okay, thank you so very much. And on behalf of the committee, I would like to apologize for any technical errors or if we have stepped on anyone's toes. Everything good comes from the Almighty, and the knots are from us lowly beings. See you next time. You may now leave this session. Thank you.
Thank you.
Thank you, Professor Alex, Professor Rafdzah, and Dr. Yodi for joining our webinar. It's a lot of information I get today.
Welcome.
Thank you very much. Thanks for
Thank
hosting.
you. Yes.
Okay,
All
welcome.
right.
Take care.
Okay. Bye bye.